We'll just get started. So we're going to talk about follicular and mantle cell lymphomas in terms of what expectations are from a cellular therapy standpoint. Here are my disclosures in terms of consulting, patents, and whatnot, as well as research funding from Kite and Novartis. So we'll start off with follicular lymphoma. Now, what we know is that follicular lymphoma is the most common type of indolent non-Hodgkin's lymphoma. It typically is a relapse remitting pattern of disease, often slowly progressing over several years. In comparison to DLBCL, we can see that DLBCL does make up the majority of non-Hodgkin's lymphomas, but again, follicular lymphoma is about 70% of the indolent non-Hodgkin's lymphomas. Most patients are actually diagnosed with advanced stage disease, mainly considered incurable, largely because this is a slowly progressing disease that builds up over time. Follicular lymphoma can transform, and there's about a 2% per year risk of transformation to a more aggressive subtype of transformed follicular lymphoma, in which case you'd be treating more like a larger B-cell lymphoma. Some risk factors that are associated with follicular lymphoma include smoking, high BMI in adulthood, sedentary lifestyle, autoimmune disease, and some exposure to pesticides and herbicides. So when you look at the NCCN guideline in 2022 for treatment approaches, it really depends on tumor burden, but chemoimmunotherapy regimens remain the standard of care for first and second line. So when you're looking at first line treatment strategies for these patients based on stage 1, 2 versus stage 3, 4, you can see that in some cases, you can consider radiotherapy combined with chemoimmunotherapy. In some instances, you can consider chemoimmunotherapy and/or observation depending on severity of the disease. When you're looking at stage 3, 4 disease, in terms of evaluation to treat, you're talking low versus high tumor burden. In most cases, you can actually observe, but in many cases, you're talking about things like BENDA-R, R-CHOP, CVP, LEN-R, or LEN-O. In this cases, we're thinking normally about palliative radiations for symptomatic patients. And for elderly patients who are typically frail, we're thinking about monotherapy-based approaches. If you do achieve a complete response or even a partial response, is very often in consideration to proceed forward with some kind of consolidated therapy. When you're looking at second-line therapies, these are patients who do relapse. Look for basically low tumor burden versus high tumor burden. Again, if you do have low tumor burden that's asymptomatic, typically we're not treating these patients, whereas with high tumor burden patients, we're considering chemoimmunotherapy, clinical trials, and whatnot. Again, frail elderly patients are typically given monotherapy with consideration for consolidation with subsequent therapies. High tumor burden basically requires regimen one of the following, meaning that you have a tumor burden of 7 centimeters, greater than 3 or more nodal sites, these symptoms, splenomegaly, compression syndrome, or pleuroperitoneal effusions, or any kind of cytopenias or associated circulating disease. So when we look at patients overall, about 20% or about 1/5 of patients are going to be considered high risk or have poor prognostic factors with multiple relapses with a 5-year overall survival around 35 to 50%. What we know is that patients who are double refractory or have progression of disease within the first 24 months of completion of therapy, these folks are going to be pretty poorer outcomes. We know that there are other histological variations, genetic heterogeneity, looking at Ki-67 and overall growth kinetics of the tumor, and again, looking at tumor burden and disease stage is what we just talked about. So there's a range of different factors that we consider when we're looking at patients and overall prognosis with this diagnosis. Now, if you do have progression of disease within the first 24 months after first-line R-CHOP based regimens, we know that they actually have a significantly poorer overall survival. So looking out here at around 84 months, you can see that the overall survival is around, 5-year overall survival is around 50%, where the 5-year overall survival for patients who don't have POD24 is around 90%. So this does, POD24 does note a very high-risk patient population who have significantly poorer outcomes. Looking at this, we also know that around 20% of patients with follicular lymphoma will experience progression of disease within 24 months, meaning that about 1/5 of these folks are going to be requiring some kind of subsequent therapy thereafter. And then looking at overall survival outcomes, shortened subsequent lines of therapy. So this is a US retrospective series of analysis from 1998 to 2009. Again, this is an older series, but the overall trend here is that both PFS and overall survival do decrease with subsequent lines of therapy. You can see that, 6-line patients, they can add up, do again have a very poor overall survival going on around 5 years. So again, sequential therapy in these folks has diminishing returns as well as worse prognosis. Now, this is the Scholar 5 data where they actually looked at treatment regimens that were utilized in third and fourth line therapy. So this was an international retrospective cohort study of real-world patients who were initiating third line or more or later lines of therapy after July 2014. You can see in third line in Europe, also in fourth line therapy, you can see that many patients are trying to go on autologous stem cell transplant, a subset were going on to allogeneic stem cell transplant. A lot of them are based on CD20-based therapies, monoclonals and bendamustine, with a mix of many other chemoimmunotherapies, experimental trials, or tyrosine kinase inhibitors. When you move out to fourth line, you can see that around a quarter of patients who are going to be going on to experimental therapies, given that they've already been exposed and have progressed on majority of the various targeted therapies, immunotherapies, as well as chemoimmunotherapies. And so when you get this far out, these patients are relatively refractory. They're typically looking for options in this late stage disease. So there's obviously, based on this data, a clear unmet need in patients who relapse refractory follicular lymphoma and those who have high risk with poor prognostic factors. And again, patients with high risk features, including high FLIPI scores, high tumor burden, and patients who are double refractory to CD20 and alkylating agents. We know that these patients who have progression disease within the first 24 months have poor outcomes, and patients that have failed multiple lines of therapy, sequential lines of therapy, typically have poor outcomes. So this brings us to the ZUMA-5 study. This was a phase 2 study, a single-arm study evaluating Axicabtagene, ciloleucel, and relapsed refractory follicular lymphoma, as well as marginal zone lymphoma. The approval in the U.S. is based on follicular lymphoma, not marginal. These patients follow the typical workflow for a CAR-T trial. You had to have relapsed refractory follicular lymphoma grade 1 to 3A, or marginal zone lymphoma, have 2 or greater prior lines of therapy combining a CD20 monoclonal antibody and alkylating agent. The primary endpoint here is overall response rate. Patients are allowed to receive bridging therapy at the investigator's discretion. They get standard conditioning lymphodepleting chemotherapy of fludarabine 30 mg per meter squared. That's if you can get it these days, and cyclophosphamide 500 mg per meter squared. And then they receive 2 E6 positive cells per kilogram of body mass on day 0. Other secondary endpoints include CR rates, overall response rate, and CR rates in patients who receive more than 3 lines of therapy. Again, other things like duration of response, adverse events, and safeties. And here we look at the post-treatment assessment. And then there were 15 centers in the US and 2 centers in France who did participate in the ZUMA-5 study. Looking at the overall baseline characteristic for this group, the follicular lymphoma subgroup, which was the basis of the subsequent FDA approval, had about 44% of patients had a high FLIPI, about 55% of patients had progression disease within 24 months. 63% had grade 3 or more lines of therapy, and 8.2 months was the median time from initiation of the last regimen to progression of disease. So overall, these baseline characteristics are pretty high risk and would otherwise be considered poor prognosis, even with subsequent lines of therapy. And looking at the baseline characteristics in the fourth line or later group, which was around 75 patients in the cohort, around 30% received prior autologous stem cell transplants, around 24% overall. Around 40% of patients in this later stage group have received prior PI3 kinase inhibitors, with again a quarter of patients overall having received that in a total cohort of 124 patients. Now, despite having these high risk factors, when we look at the overall response rates here, we can see that the overall response rate was actually very, 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 very high. So we had a CR rate of around 79% and a PR rate of around 15%. And this was the best overall response. When you look at the 24-month analysis, and so this provided a median follow-up of all patients of 34 months, we can see that the median duration of response was 38.6 months, and 66% of patients had an ongoing response at 2 years. And so as I had shown previously, when you're looking at these folks, most of these patients have progressed on their prior line of therapy within 8 months. And we're looking at a median duration of response of 38.6 months. So a pretty remarkable outcome in extremely high-risk patients with otherwise poor prognostic factors. Again, looking at patients if they had 3 or more lines of therapy previously, they had similar responses to the overall population. Again, this is consistent across CAR-T studies, where we actually find that patients in general don't typically follow the same prognostic factors for chemoimmunotherapy-based regimens. And then you're looking at patients with POD24 had similar overall response rate and 18-month response rates for those without. So again, another high-risk component that otherwise would consider a poor prognosis did not seem to matter in terms of cellular therapy. Now, looking at the overall population here, so when we looked at high rates of overall survival in these groups, with 63% of patients progression-free as of 2 years. Again, this is with 31 months of overall follow-up. So the PFS here were largely consistent across all follicular lymphoma subgroups. And then again, 25.9 months median follow-up, the median PFS in patients who received Axicabtagene, the fourth line or later, was 40.2 months. So again, going with the theme here that overall, many of these patients actually aren't with high-risk features, highly chemoimmunotherapy and targeted therapy, relapse refractory disease, are responding equally as well to cellular-based therapies, regardless of the prior therapies. And again, this is also going in the same trend in the POD24. So very nice data here, basically showing that CAR T seem to be ignorant of prior therapies and other high-risk components. Looking at the overall safety in this patient cohort, so it was largely consistent with what we know about Axicabtagene. So looking at the grade 3 or higher adverse events we're seeing in 85% of patients, most common were things like cytopenias or infections, which I think we expect, at least from an infection standpoint, from Dr. Sauter's last comment, though. Cytopenias are an ongoing problem in cellular therapy and something that's currently ongoing. In terms of severe adverse events, we're typically looking at cephalopathy and pneumonias. For grade 3 or higher CRS, I will say that this at 6% is actually lower than what we would typically expect in large B-cell lymphoma. And grade 3 or higher neurological events, including encephalopathy and confused state, were only 15%, which is about half of what we would expect to see in a large B-cell lymphoma cohort. I think this is largely due to the fact that although we're using the same cell therapy product, same genetic construct, we are dealing with different disease histologies here. And when you look at patients who had either high-risk features like POD24 or not, the rates of grade 3 or higher adverse events were generally similar in both patient cohorts. And so overall, we didn't see anything new coming up in the 24-month analysis, but this is, from a cell therapy standpoint, 6% grade 3 or higher CRS and 15% neurological events seems to be a pretty manageable approach. Now, there's another approval in the US based on the ELARA study, and so this is for Tisagenlecleucel. This was a single phase 2 study in T-cell in patients 3rd line or later, median of 4 lines of therapy. 76% of patients are refractory to greater than 2 or more lines of therapy. And again, this followed very much similar workflows where you had to have follicular lymphoma, had to have relapse on 2 or more lines of therapy, or relapse within 6 months after 2 or more lines of therapy following a transplant. There's no evidence of histological transformation, and you were not dealing with large cell transformation, and you couldn't have received prior CD19 or allo-based therapies. Looking at the overall study workflow, we can see here, patients were given 250 mg/m² of Cytoxan and 25 mg/m² of fludarabine for lymphodepletion. And we're looking at the median follow-up of the infused set, so 97 patients out of the total cohort, we had a median follow-up of 10.6 months. Now, the efficacy cohort of 94 patients was 10.9 months of follow-up. Looking at response rates, we again have very high overall response rate of 86.2%, a CR rate of 66%, a PR rate of 20%. Looking at the overall complete response rate by investigator assessment, it's around 69.1%. And again, the CRs and overall response rates were comparable, again, across high-risk subgroups, really highlighting that cellular therapies are somewhat unique in their ability to target this type of patient subtypes. And the probability of patients remaining their response beyond 6 months was 79% based on this reported cohort. I do think it is important to note that 38.7% of patients, so 12 out of 31 partial responders, did convert to complete response. And although one occurred between months 3 and month 6, and so typically when we're looking at these patients, we're typically thinking about doing restaging scans later than we would otherwise consider for large B-cell lymphoma, or at least repeating them at later time points until achieving best overall response. And then again, we've seen an overall survival here will be very favorable. Again, the complete response rate was consistent across all subgroups, including relapse refractory, multiple prior lines of therapy, and refractory disease, including POD24. At the extended follow-up analysis, which was about a median of 17 months, The overall response rate and CR rate were consistent at 86.2 and 69.1% respectively. I'm looking at a median PFS of around 29.5 months, the median follow-up of 21 months. So again, very favorable data. Now, looking at the safety profile, most CAR-T patients have some degree of adverse events, and I'll kind of just skip over the basic that we're looking at here. I will say that tocilizumab use was around 34%, and around 6% of patients did require steroids. Looking at CRS, unlike Axicabtagene, we didn't see any grade 3 or higher CRS. Everything was predominantly grade 1 and 2. We saw a very low rate of neurologic events, 1% versus 15%. Similar rates of infections, very little concern for tumor lysis syndrome. And again, we did actually see all grade and grade 3 or higher neutropenia, anemia, and thrombocytopenia. Again, highlighting the component here that cytopenias are an ongoing issue when considering cellular therapies. But overall, very favorable safety profile from a CRS and neurological standpoint, and there are no treatment-related deaths. So when we compare, historical outcomes in relapse refractory follicular lymphoma, we're basically looking at some similar studies here. And when I'm thinking about how do we compare this to alternative therapies, we can compare ZUMA-5 to SCHOLAR-5. And so here you can very clearly see differences of overall response rate, 94 versus 50%, higher rates of CR, 79 versus 30%, a very favorable overall survival. Looking at Tisagenlecleucel in the record follicular lymphoma study, we can see response rates of 86 versus 64%, and CR rates of 69 versus 37%. So again, very favorable PFS and overall survival findings in the highly relapsed refractory group in both ZUMA-5 and the ELARA study. So NCCN guidelines are now based on third line and subsequent therapies are now recommending anti-CD19 CAR T cells after 2 or more lines of chemoimmunotherapy, recommending both Axicabtagene, ciloleucel, and Tisagenlecleucel in the third line setting. So this is now the current standard for what we're doing in the United States, and I can say at our center we're pretty CAR heavy, so this is what we're currently favoring. Looking at the overall summary, we know follicular lymphoma is a rather indolent disease. It is considered to be incurable, and patients typically do have poorer outcomes if they have high-risk features. The baseline is chemoimmunotherapy in the first or second line setting, and then we really have a mixture of therapies in the third line plus. Those include targeted therapies, experimental therapies, and now thankfully CAR T cells, which are approved in the United States. We do have approvals for Axicabtagene, ciloleucel, and Tisagenlecleucel, and they have demonstrated high response rates of 80+% with high CR rates, regardless of the subgroups, including high-risk patients, patients with POD24, or multiple lines of therapy. In all studies with longer follow-up, we haven't seen any increased safety signals. And when we looked at the single-arm studies, the outcomes and PFS overall survival, as well as response rates, are very favorable compared to what we would consider in our historical data. And then looking at this moving forward, we're looking to see whether this is going to dramatically in long-term improve patient outcomes compared to prior therapies or other therapies. So with that, we're on to follicular lymphoma and CAR T cells. I'll move to mantle cell lymphoma. So mantle cell lymphoma is around 4% of non-Hodgkin's lymphomas, and it's rather rare and aggressive. The majority of patients do tend to have more aggressive disease. They typically present with more advanced stage disease. The annual incidence is 1 to 2 per 100,000 in Western Europe. Each case of mantle cell is unique and exists in a high spectrum ranging from high to low risk factors, but looking at, again, a very rare subtype in terms of 4% of overall non-Hodgkin's lymphoma, with the majority being aggressive subtypes. So looking at the overall NCCN guidelines and recommendations for mantle cell lymphoma in the first and second line therapy. So looking for a stage 1 or stage 2 non-bulky, typically we're thinking chemoimmunotherapy with or without radiation or radiation alone. You have non-contiguous, meaning you're typically looking at more systemic therapies like chemoimmunotherapy with radiation consolidation. You typically observe these patients in some selected cases. And you have more bulky disease, stage 2, 3, or 4. It really depends on your TP53 mutation. So if you're TP53 wild type, typically acts more indolent. If you're a candidate for an autologous stem cell transplant, we typically consider induction chemotherapy. There are many, many different regimens that can be considered, followed by high-dose chemotherapy and stem cell rescue, and some form of maintenance therapy like Revlimid or Taxan, I'm sorry, thinking myeloma. If you're not a candidate for autologous stem cell transplant, you're typically looking for other types of aggressive induction regimens or clinical trials. With TP53 mutated, these patients typically have pretty adverse outcomes, and they're typically looking at clinical trials or chemoimmunotherapy with indolent disease just having more of observation. The patients who have relapse refractory disease, so in their first relapse, typical standard of care in most settings would be a BTK inhibitor containing regimen, where basically these patients are going to be on chronic therapy for an extended period of time. You can consider things like lenalidomide or Rituxan if BTK inhibitors are contraindicated, although a number of BTK inhibitors with fewer side effects and cardiac events are now becoming available. And then you're typically considering some kind of autologous regimen if needed. In terms of other time-limited regimens, you can think about things like radiation for more focal or smaller disease burden. But again, these patients are eventually going to relapse. Looking at the progression-free survival, again, just like in follicular lymphoma, when you look at the median PFS of first, second, third, fourth, and fifth line plus, we're really looking at a median PFS of around 47.4 months down to 3.2 months, with at the third line setting a median PFS of around 6.5 months. So these patients overall do pretty poor with subsequent lines of therapy, and this is data that were from Memorial Sloan Kettering from 2000-2014, and 404 patients. Well, again, following the trend that the more relapse refractory disease you have, the poorer your outcome is going to be in terms of PFS, which largely translates to the poor overall survival and patient outcomes. Now, some of the risk factors we talked about already in terms of high-risk components, that includes being TP53 mutated, having a high MIPC score, having a blastoid cytology, having a high Ki-67 index, or having complex karyotype. So these are some factors that typically will convey poor outcomes in this patient population. Patients, again, with early progression of disease within the first line of therapy do have an overall decreased overall survival when compared to those who relapse beyond 24 months. So the median overall survival of patients with early progression disease was 1 year versus not reached for those with later progression of disease. So here again, just emphasizing that early disease progression in both follicular and mantle cell lymphoma typically confers a poor outcome and poor overall survival going on out multiple years. In high-risk relapse refractory mantle cell lymphoma, allo transplant remains really the only curative option. It's just very hard in many instances to get patients with relapse refractory mantle cell lymphoma to an allogeneic stem cell transplant, largely because you do need to have patients in a sufficient response in order to proceed. And so when you look at patients here, the 2-year overall survival is around 53%. In a multi-center retrospective analysis of patients who did receive the reduced intensity allogeneic stem cell transplant. And this was typically done because patients tend to be older, have additional comorbidities, and so we're not usually using myeloablative regimens in this situation. But overall, again, even with some of the best therapies in the patients who are optimized to undergo an allogeneic stem cell transplant, the 2-year survival is only 53%. And again, pointing out that with transplant, the 2-year treatment-related mortality is around 32%. So those are typically things like infections, graft-versus-host disease, typically poor outcomes in that setting. BTK inhibitors really kind of changed how we were addressing mantle cell lymphoma. And despite having these, more than 50% of patients will relapse within 2 years of second-line BTK inhibitors. And this is usually from some kind of acquired resistance or some primary resistance. And we've seen this in about a third of patients who start on ibrutinib, although we're using new second and third generation BTK inhibitors more commonly. And we do know that BTK inhibitors do have poorer activity, especially in those TP53 mutated subtypes. And then the survival rate for patients who receive subsequent therapy after ibrutinib-based therapy is around less than 9 months. So overall, BTK inhibitors do provide a large degree of early benefit. And but patients do end up progressing subsequently thereafter. And so our common practice is to use BTK inhibitors as more of a bridging therapy if we're thinking that things like CAR T cells are actually going to be viable. There's some other data supporting the use of BTK inhibitors actually improving overall T cell quality, but we won't have time to get into that right now. And there's actually no clear way to sequence therapy. So looking across various countries, mostly in the US, internationally, the EU, we can see that there's a wide range of different therapies that are currently utilized following BTK inhibitor, following progression on a BTK inhibitor. But overall, the overall response rates across these different cohorts are pretty low, ranging from 26 to 83%. The median overall survival peaking at 12.5 months. But again, there's no real standard of care. And these patients are typically have a poor overall prognosis following failure of the BTK inhibitor. And so when you think about effective therapies, you got to look at patients, you're going to consider patients with high-risk disease features and how we're going to apply these therapies to them. We have to consider the patients who have relapsed after after a BTK inhibitor, primary therapy, including autologous stem cell transplant. The early progressors tend to be more difficult, and we do have to consider frailer patients because as you escalate the intensity of the regimen, many older patients can't necessarily tolerate it. So the ZUMA-2 study gets into Axicabtagene. So this was a phase 2 study of Axicabtagene, brexucabtagene autoleucel. So the main difference here is that Axicabtagene is a non-T cell selected product when they start manufacturing, whereas a T cell selection component in brexucabtagene, given that with mantle cell lymphoma, you can actually have circulating disease. And to avoid somehow transducing CAR T cells or disease with the CAR transgene, there is a T cell selection component here. Interestingly, as a side note, this was actually found to be a resistance mechanism in B-ALL at least, where it was termed CAR-B, where you actually transduced the circulating blast with a CAR, which then binds the CD19 epitope on the cell surface and masks it from subsequent killing. So really important that there is a different manufacturing process, although it uses the same genetic construct. So in this study, patients are screened, enrolled in leukapheresis. They're allowed to get some degree of bridging therapy, including steroids or ibrutinib. They got a baseline PET scan, and they ended up getting chemoimmunotherapy for lymphodepletion. Again, flu 30 mg per meter squared. I think we passed my 100. Sorry if you can hear my dog. Brexucabtagene was given at 2E6 CAR-positive cells per kilogram on day 0. And on week 4, they had their first tumor assessment, the primary endpoint being overall response rate. Again, looking at duration of response, PFS, and overall survival, including adverse events in this cohort. So looking at the ZUMA-2 cohort here, they actually had a pretty, high-risk features are pretty common. So a quarter of patients had blastoid variant morphology. 17% of them had TP53 mutations. Almost, well, 3/4 or 2/3 had a high Ki-67 index over 50%. Over half of patients had an intermediate high-risk MIPI score, and all patients had BTK relapse or refractory disease. So something to point out here, based on our prior conversation, for overall response rates and overall survival. So what proportion of patients achieved a response in this cohort? Is actually the overall response rate was remarkably high, 91% with a 68% CR rate. These data are somewhat unheard of. And the initial time to initial response was 1 month, and the median time to CR was 3 months, highlighting again that looking at this patient, from the New England Journal population, but we did actually see conversion of patients who initially had a PR or stable disease for complete response, with a median time to response conversion of 2.3 months. So again, pointing out here that 91% of patients with relapse refractory, BTK inhibitor refractory, mantle cell lymphoma achieved a response with brexucabtagene autoleucel. So not an easy task, but very promising. So in terms of the overall survival and progression-free survival, so this was based on the ASCO 2022 data. 24-month PFS was actually 52.9% of all patients, and the median PFS being 25.8 months. Looking at the overall survival, the estimated around 83% of patients alive at 12 months, and 60.3% of patients at 30 months, the median overall survival of 46.6 months. So again, highlighting an improvement in the progression-free survival and overall survival. Again, the highest we saw post-BTK inhibitor therapy was about a year, depending on what cohort you look at. And here we're seeing an overall survival improvement with a median overall survival for 46.6 months. And this was with a median follow-up of 35.6 months, so pretty long-term follow-up here. Looking at the brexucabtagene and outcomes in patients with high-risk features, so looking at the blastoid morphology, TP53 mutations or high Ki67s, you can see that we really didn't see significant changes in this cohort, but basically PFS and overall survival are consistent across the subgroups, regardless of things that we would classically consider poor prognostic features. So again, a very common theme as we're seeing in mantle cell and follicular and large B-cell lymphoma is that in many instances, high-risk components or features that we think are poorly prognostic do not translate over to a cellular-based therapy. And then looking at patients who had progression of disease within 24 months, again, PFS and overall survival are relatively similar. And looking at both with or without, the overall survival wasn't reached at a median of 17.5 months. So these folks are actually doing equally as well. Looking at the overall safety profile compared to it was comparable to ZUMA-1. So again, we did see adverse events and severe adverse events, but I'll just focus here on grade 3 or higher CRS of 15%. There's 31%, a little bit higher, not sure if it's statistically significant than what we would overall consider in the from the ZUMA-1 study. But long story short is that this again seems to be acting more like Axicabtagene in large cell lymphoma, whereas we did see decreased toxicity with the follicular lymphoma cohort of Axicabtagene. And again, there are no grade 5 CRS and neurological events. I think a lot of this has to do with our improvement in overall management of these patients. And then again, looking at how does this compare overall. So comparing brexucabtagene to autoleucel, we do see an overall survival improvement. And this is comparison of ZUMA-2 to the SCHOLAR-2 study. And so I think it's pretty readily apparent here that we are seeing improvements in overall survival going out to around 36 months in patients who do receive brexucabtagene or standard of care or historical controls. So from that, based on the NCCN and ABN2 recommendations, we actually now have for third line or later, we do see it for NCCN that we do recommend brexucabtagene autoleucel. And in some instances, I just will say based on the FDA label, it doesn't actually require failure of a BTK inhibitor. And so I just want to emphasize that in many instances, when patients are starting a BTK inhibitor, they're already really thinking about the discussion of what to do and when to bring a patient to CAR T. And we've also seen that here for CAR T cells, for later lines of therapy for EBNT proposals, we're seeing that there is some recommendation here and consider standard of care for use of brexucabtagene. So just in summary, as I'm getting closer, I've already passed my time by a little bit. Mantle cell lymphoma is a rare disease. There's no real recognized standard of care dependent internationally across various lines of therapy. We know that brexucabtagene showed high response rates and consistent overall survival improvements regardless of high-risk features. Again, safety was pretty consistent with what we expect from both Axicabtagene and brexucabtagene, and it did appear to actually have favorable outcomes when compared to historical controls, although this is not a randomized phase 2 study. And then we do believe, or at least I believe, that we're improving outcomes in this patient population overall. So thank you.